Today, I want to go over a bird's eye view of anesthesia. As a student, I had a very hard time understanding why we were learning the certain devices and the certain drugs that we were learning. I had a hard time understanding why you would ever want to use an LMA if you have an ET tube option. Why do you care about the side effect profile of Robenal versus atropine versus scopolamine? I knew how to memorize and study things, but I had a very hard time assimilating all this information into one graphic. How did all these puzzle pieces fit together? That was my question. And I actually decided to make a giant map that I tried to find today, including all of the topics like LMAs, nasal cannulas, TIVAs, generals, all of this, but I guess I lost that piece of paper during the Great Purge after I passed my boards, so I'm going to try to recreate a better, more correct version of it today. So, let's first go over the types of anesthetics. There are three main broad categories of anesthetics. There's a general anesthetic, an IV sedation anesthetic, and a regional anesthetic. IV sedation is typically referred to as moderate anesthesia care, or a MAC, whenever an anesthesia person is involved in the case. If there is no anesthesia personnel involved, then it's just IV sedation. So how do you know which one to use when? Well, in most cases, it is dependent upon the patient, the surgeon, and the surgery. So what do I mean by that? Well, if it is a healthy ASA1, no comorbidities, and it's a simple procedure, like a carpal tunnel surgery, you can probably get away with a MAC anesthetic and some local injections, and the patient will be fine. Now, if it's a very complicated case, like a kidney transplant on a patient that has problems with their heart, they had an MI in the last year, they have problems with their lungs, they have COPD, they have problems pretty much with every organ system, then you're going to want to impose more control over the patient. So you're going to want to have an E2 tube, you're going to want to have an A line, you're probably going to want to have a second IV, you're definitely going to want to have a second IV. So the anesthetic you choose and how invasive your anesthetic is, meaning how many lines do you have, did you start an IV, are you going to use an ET tube versus an LMA, is dependent upon the surgery type, the patient, and the provider skill and comfort level. So let's get back to the topic at hand. What kind of anesthetic are you going to use? Are you going to use a general, a MAC, or a regional? Which one do you use and when and why? Well, let's start with monitored anesthesia care, which is IV sedation with the involvement of an anesthesia provider. If there's no anesthesia provider, it is just IV sedation. This type of anesthetic is usually given for cases that are quick and for patients that are generally healthy, like a carpal tunnel surgery for a 30-year-old male that has no health problems. For this surgery, you would start a propofol drip or do boluses of propofol, and the surgeon would inject some local anesthetic to help reduce the amount of pain intraoperatively and postoperatively. This type of anesthetic is also commonly used in endoscopy procedures, such as EGDs and colonoscopies, and for knee replacement procedures with the involvement of a spinal anesthetic. So for a knee replacement, the anesthetic would be the spinal, and the IV sedation, so the propofol drip, would just keep the patient comfortable during the length of the surgery. Since we're talking about regional anesthesia, let's go over spinals, epidurals, and nerve blocks. Spinals are typically used for lower body surgeries, typically C-sections, orthosurgeries such as knee or hip replacements, some urology cases, and some OBGYN cancer procedures. A spinal is essentially a small amount of local anesthetic injected into a specific space, typically a lumbar space, that provides a dense nerve block up to a desired dermatome level. Next, we have epidurals. Epidurals also involve an injection of a local anesthetic into a specific space to provide relief. It is slightly different in the approach and the fact that it involves a catheter that stays in the patient and provides a continuous injection of local anesthetic. Lastly, we have nerve blocks. These are injections around specific nerves, commonly using ultrasound, that numb up a desired part of an extremity for 24 to 48 hours depending on the effectiveness of the block and the type of local anesthetic used. Also, they can have a continuous catheter in place as well, such as interscalene blocks. This is the most common basic rundown of the three regional anesthetics. There's a lot more that goes into each one of these topics, but again, this is a bird's eye view of anesthesia. Lastly, we have general anesthesia. General anesthesia means the patient is going all the way to sleep. This can be achieved either through volatile anesthetics, such as sevoflurane or isoflurane, or with intravenous anesthetics, such as propofol. How do you know which one to use? Well, typically, TIVAs are used in a few situations. Again, this is not an all-inclusive list, so keep that in mind. TIVAs are typically used for brain surgeries, such as craniectomies and craniotomies, to help the neurosurgeon, or in the case of PONV, where the patient experiences postoperative nausea and vomiting. There are some patients that are more prone to this than others, such as young, non-smoking females that tend to get car sick. So when do you use a volatile anesthetic then? Well, pretty much in any other scenario that I haven't already described. Now, can you use a gas with an LMA for carpal tunnel surgery? Sure, but it might be a little bit overkill. You might be providing too much anesthesia for the type of surgery, the length of surgery, and the health of the patient. Sometimes it's heavily dependent on the provider preference. I have a colleague that completely avoids using LMAs if they can help it. Does that mean they're a bad provider? Absolutely not. It just means that they probably don't feel very comfortable with LMAs and would rather provide the safest anesthetic they can provide, which means not using drugs or devices that they don't feel comfortable with. As a student, most things you're using make you uncomfortable, so it's a great time to rely on the comfort level of your preceptor to learn new things and new approaches. Which leads me to our next topic, airways. Now that you've decided that you're going to do a general anesthetic, the next question is, what type of airway should you use? Well, you typically have two options, an endotracheal tube or a laryngeal mask airway. In some cases, such as when you're doing a room air general, which can sometimes be found in endoscopy suites, you're not placing any kind of airway beyond a face mask or a nasal cannula. But typically, if you're performing a general anesthetic, you're doing it by placing an LMA or an ET tube. So which one should you use? Well, that depends on whether you have any fear of the patient refluxing and aspirating. If the answer is yes, it's an ET tube. If the answer is no, then you might want to use an LMA. Next question. Does the patient meet the requirements for an LMA? Meaning, can you safely ventilate the patient without exceeding an inspiratory pressure of 20 while the patient is lying supine or laterally? Side note, personally, I never place prone LMAs. If something happens, I cannot easily secure the patient's airway if they are prone, and therefore, I do not place prone LMAs. So, can you ventilate the patient supine without exceeding the inspiratory pressure of 20? If the answer is no, then your patient will likely need an ET tube. If you're using a Supreme LMA, that inspiratory limit changes from 20 to 30. Next, does the surgery require a certain level of relaxation? If the answer is yes, because it's an open belly case, for example, then you're going to need an ET tube. Some of the questions you might ask are, does the patient have a reactive airway? Is this scheduled to be a long procedure? And if so, are you able to provide the patient's respiratory support via PSV Pro for several hours so they don't get tired? It's hard work breathing through a small tube for several hours with no assistance. That's a lot of resistance the patient has to overcome over several hours. In most cases, the safest airway you can choose is an ET tube. That is a secure airway that you can use for many hours regardless of the patient's position. An LMA is a glorified oral airway, which means that it helps keep the tissues out of the way as you ventilate the patient. Because when you administer anesthetics such as propofol, volatile anesthetics, these tissues relax and start to occlude and obstruct the airway. You can actually bag mask ventilate for the cases that you use an LMA for. Is it comfortable? Absolutely not. Is it the most efficient practice? Nope. But is it an option? Yes. I've had preceptors make me bag a patient with SIVO for the duration of a 30-minute procedure to improve my bagging ability. So just keep that in mind. Now, let's quickly go over some of the airways mentioned in Nagelhout's airway management chapter. So here I'm going to go over different types of supraglottic airways. I'm going to list out the most notable features of each. So we've already talked about the standard LMA. Here we have the ProSeal or Supreme LMA. The Supreme is just a disposable version of the ProSeal. These are double lumen LMAs with a gastric drain tube. They have a larger mask and a bite block. Also, the most notable feature is that they provide a better seal, which allows for a max inspiratory pressure of 30 instead of 20 centimeters of water, as seen in the standard LMA. Here's a fast track LMA, which is an intubating LMA that you can help blindly intubate a patient. It can be helpful in situations where you can no longer visualize anything with DL or fiber optic because the airway is too bloody and too swollen. Air cues are also intubating LMAs, but they allow for better bronchoscopic viewing, hence why we use them in BronchLab, and they're easier to place than the standard LMA. Combi tubes and King LTs are double lumen airways that can be inserted blindly. These are secondary rescue devices that are used when intubation, bougie, LMA failures occur, and you won't really see them in the OR setting. They're more popular, or were more popular, with EMTs in out of hospital settings. Combi tubes provide a secure airway when placed correctly, allow for the decompression of the stomach, you can insert them blindly, and they allow for high ventilatory pressures of up to 50 centimeters of water, again, when placed proficiently. There are various types of bougies which can assist you with intubation, such as the lighted stylet and the gum elastic bougie. There are also flexible fiber optic scopes and stylets that can also serve the same purpose. Video laryngoscopes such as CMAX, glide scopes, McGrath scopes can be used as an alternative to direct laryngoscopy in situations where you might expect the airway to be difficult or if there is cervical instability. Okay, I'm going to cut it off at this point. I can make a video in the future about anesthesia start time and anesthesia stop time and everything that happens in between, including induction drugs, maintenance drugs, emergence drugs, what you would give when, why, what are things you're looking out for, just an overall bird's eye view of a typical case anesthetic. Let me know if you guys have any suggestions for improvement of the channel, the videos, if you guys like certain things that I'm doing, dislike certain things that I'm doing. Any and all feedback is appreciated. And as always, I hope you guys have a wonderful day.